everyone knows the stem cells, you can get it from embryogenic stem cells or adult stem cells. You can get it from bones, blood, umbilical cord, from blood, or adipose, mesenchymal stem cells. International Society defined that the cells must be plastic adherents, biomarkers, CD 73, 90, 105, 45, and 34, differential toward mesenchymal stem cell, osteoblast, chondroblast, adipocyte. Always you have to do a cytometry. Our labs, we span and certify. Which is the action of the mesenchymal stem cells? Regulation of immune system, decreases inflammatory process, decreases inflammatory interleukins, disappears activity of CD4 and CD8, increases anti-inflammatory factors, and increases immune regulators cells. As you can see here, mesenchymal stem cells is very important in adaptive immunity and innate immunity, and in the differentiation and reprogramming. The other activity of stem cells is very important is the secretomes, modulation of inflammatory cells, chemoattraction, proliferation and differentiation of progenitor cells, and angiogenesis. Of all the action, the ultimate goal is homeostasis. And what about? Which is better, autologous, allogenic? Usually we use allogenic because with the age, decreased function cells with age, availability, and the cost. For us, it's better to use allogenic therapy. For example, in the knee, we have an injury, knee, arthroscopy, put the cells, and you can see the first week, the lesion, then 6 weeks, repair, and after 4 months. Injury pre-injections, after, chondrocyte, and chondroitin sulfate staining. Disc. We all know how is the physiology or physiopathology of the disc. We have problem in the end plates, the nucleus, and the annulus. We can separate 3 different diseases: plateau, annulus, and nucleus. We have a problem here: burden of illness, minimal treated option, unmet needs, market opportunity. How many chronic low back pain we have and we don't know how to treat it? Because the surgery or the endoscopic surgery or minimal invasive surgery is only 1-2%. And a lot of works now is trying to get an answer to this degenerative disease. A lot of studies we advance, we have autologous cell-based technology, allogenic cell-based. For example, we have a lot of works now in different companies because it's a very burden disease. We have more than 10 or 50% of the population with chronic low back pain. We use intradiscal mesenchymal stem cell therapy. A lot of work can say that regenerative properties are due to immunomodulatory properties. Secretion of paracrine and exosomes prevents cellular apoptosis. We are working now in exosomes a lot because it's very useful. It's very good for the pain of the degenerative disease. Here another work, mesenchymal stem cells, safe and efficacy, rehydration of the disc, important decrease of pain, 2-year follow-up. Allogenic mesenchymal stem cell therapy, mesoblast, dysgenic, and spinal side, a lot of human tests. 6 million, they use 6 million intradiscal, anti-inflammatory effect, nucleus and annulus stimulation, synthesis of PG and collagen. They are in phase 2 with 36 months follow-up, good result in pain and oswestry. Now, phase 3, 360 patients. Can you run the, okay. Can you run the video? This is an example how we use the stem cells inside the, run the video. No? No, okay. We published in Pain Physician in 2023 this work. We use between 8 million to 50 million each disc. We combine with hyaluronic acid and we put intradiscal in a patient with oswestry with more than 20 and with pain more than 5. That is select patient. The results are very good. As you can see here, the VAS have a more than 4 and 5 point decrease, and a postoperative MAGNAV, excellent good result was around more than 90% of the patient. Conclusion, allogenic mesenchymal stem cell injection is an alternative to autologous material. Tissue bank make it available, thus simplify the process of procurement and expansion. We recommend the intradisc therapy for degenerative disc disease. This published different works. Our labs. Now we are culture the hernia, the material of the hernia. We are trying to keep with the cells and freeze, and we are start putting expansion and safe for the patient in the future. Spinal injury, we have a protocol now. And with fusion, tomorrow we are speak more about fusion. Thank you very much.
Thank you, Dr. Alvaro. Any questions from the audience?
One question. In Germany, it's not allowed to use stem cells for intradiscal application. Therefore, we use PRP.
PRP.
Do you have any experience with PRP comparing to these stem cells injections?
Yeah, we have some experience with PRP. The problem with PRP, I think we We start in 2010, and we use everything. We start with bone, BMC, we centrifugate, and we try to get the cells. We do the cytometry, but was 500,000, 300,000, 1 million, but it's only few cells. And was a problem because you have to span, and you have to put the patient, you have to see the patient 3 weeks before, and then expand, and then put the 6 million or 10 million. It's not useful. PRP, the problem, have more anti-inflammatory than anti-inflammatory. And sometimes you get more pain than less pain. The stem cells have more anti-inflammatory effect, and the patient be better. And exosomes are amazing. We start with exosome because you get more powerful for pain.
Dr. Alvaro, can you tell us what is the criteria for choosing the patient in which you go for this stem cell therapy? What are the patients that you feel like should undergo stem cell therapy? If a huge disc prolapse or degeneration is too much that it is causing stenosis, you won't be going, that stem therapy won't be relieving the pain. So what are your criteria to decide which patient should undergo stem cell therapy?
Sorry, I don't get it.
The criteria, what you choose so that patient can undergo stem cell therapy and he will improve with his symptoms.
Okay, which is the inclusion criteria?
Yeah, which patient should undergo stem cell therapy?
Yeah, we use in the patient that have chronic low back pain with degenerative disease, and we always use 8 million to 15 million. That is the range. Huh? And always with the patient with more than 5 of pain, the VAS, and always with upstream more than 20. That is the inclusion criteria. Without a big hernia, not hernia, normally a DDD, degenerative disc disease.
Okay.